Good morning, one and all. I'm Dr. Harita. Today I'm going to speak on effect of cyclopentolate on ocular biometric parameters. There are no financial interest to disclose in this study. Coming to introduction, accurate measurement of axial length, anterior chamber depth, and corneal curvature are essential for calculating intraocular lens power according to different formulas. Assessing the anterior chamber depth is important to determine whether there is enough room for posterior chamber intraocular lens, as shallow anterior chamber depth or narrow angle can increase the risk of iris pigment chafing, and overestimation of anterior chamber depth can result in corneal endothelial cell damage. Cyclopentolate, it is a synthetic anti-muscarinic cycloplegic agent which is available in 0.5% and 1% solutions.
Hello.
And it is widely
1, 2, 3,
acceptable
check.
drug. It is a widely acceptable drug of first of choice for patients of all the ages, and it provides an excellent short-term cycloplegic effect. The main aim of this study is to assess changes in ocular biometric parameters before and after dilatation using cyclopentolate 1%. The objective of this study is to compare the effect of cyclopentolate 1% on the parameters anterior chamber depth, lens thickness, and axial length before and after dilatation. Coming to materials and methods, this is a prospective observational study done for a duration of 3 months. Using convenient sampling, I have taken 25 patients with cataract, and informed consent and institutional research committee approval was taken. Coming to inclusion criteria, I have included the patients of age group 45 to 75 years who are having a clear central cornea and cataract according to LOC3 grading, and no other ocular or systemic diseases. Coming to exclusion criteria, I've excluded patients with previous refractive corneal surgeries or patients having any corneal ectasia or coexisting corneal pathology. Methodology, anterior segment evaluation was done using slit lamp and ocular biometric parameters, anterior chamber depth, lens thickness, and axial length were measured using A scan by immersion technique in supine position, and the parameters were assessed pre-dilatation, and the patients were dilated using cyclopentolate 1%, 1 drop every 10 minutes for 3 applications, and the parameters were assessed 30 minutes post-dilatation after the 7 to 8 mm of dilatation, and the data was analyzed using mean and standard deviation. The parameters were compared using pair t-test before and after dilatation, and the data was analyzed using Microsoft Excel sheet. P-value less than 0.05 was considered statistically significant. Coming to results, the axial length has shown no significant difference in pre and post dilatation, but the lens thickness and anterior chamber depth has shown with p-value significant difference in post dilatation. So coming to discussion, the results of this study showed statistically significant difference in the lens thickness and anterior chamber depth post cycloplegia. Ocular accommodation increases the lens thickness and it moves the lens forward, while temporary paralysis of the ciliary muscle, it leads to an increase in the anterior chamber depth by reducing the crystalline lens curvature and backward displacements of its geometric center. So anterior chamber depth is an important factor in IOL power calculation. So imprecise measurement can lead to undesirable refractive errors after cataract surgery. Similar studies, Tao et al. Has showed significant changes in the anterior chamber depth and axial length post cycloplegia. Another study, Momenti et al. Has showed cycloplegia resulted in deeper anterior chamber depth and thinner lens thickness. Coming to limitations, I have taken a small sample size and I've used only single drug to assess the changes in the parameters. Coming to conclusion, cycloplegia can significantly affect the ocular biometric parameters. That is, it can result in deeper anterior chamber depth and thinner lens thickness. So changes in these ocular biometric parameters should be considered in calculating intraocular lens power calculation to prevent refractive errors after cataract surgery. These are my references. Thank you.
Any questions from the audience?
So in a routine cataract surgery, would you prefer to
examine ACD with cyclopentalate or without cyclopentalate?
Usually we use tropicamide with phenylephrine
Once you have,
combinations.
before you do axial scan, A scan,
It's better if we don't, if we prefer to take it before dilatations.
because the real life scenario is before dilatation. You can't keep the patient dilated.
So, but in most of the private setups, they do examine the patients after dilatation.
not necessarily,
They'll
not
measure the axial length,
Not
so it's
necessarily,
better.
unless there are something. Sometimes the A scan don't give a reading pre-dilation, or else you do pre-dilated only.
Nice. Thanks.
How did you actually exclude the corneal ectasias? Did you do any type of topography or any other instrument?
No, sir, based on anterior segment only of
Okay, only clinical
and
examination
keratometry,
and keratometry findings.
keratometry findings are taken.
Okay.
Thanks.
Any questions from the audience? Please give the mic.
There was one study you had put thioy et al., right?
Yes.
So which showed a significant change in the axial length pre and post dilatation.
Yeah, that study has shown there is
So was there any
significant difference.
reasons for your changes in the
Yes,
angle, like the anterior chamber depth and all that? So what was the pathology like behind this change in axial length
Uh,
in that study? Steve, thank you.